So my talk is titled Pumps, Pipes, and Pressure. We want to master the essentials of that. And by the end of this talk, we want to have looked at cardiac output, okay, and the determinants of cardiac output. We want to understand some terms that we've commonly had being used: preload, afterload, systemic vascular resistance. And then after we've understood these terms, we want to see how we can apply them, okay? So we'll dive right into it. Cardiac output. What is cardiac output? Simply put, cardiac output is blood flow out of the heart. Easy, right? You're not sure? You're sure? Okay. So it's easy. Cardiac output is merely blood flow out of the heart, okay? And when this blood flows out of the heart, it goes to different organs, right? So it goes to the brain, and the brain will take about 14% of the cardiac output. The kidneys will take about 22%. The splanchnic circulation, which is our gut, will take the most, which is about 27%, and then the rest will come. So the blood that goes out of the heart goes into the different organs and is distributed that way, okay? So we know these things. Mine is more of a revision talk, so we're going to present together, okay? So what are the determinants of cardiac output? Could I have a hand? By the way, there is no wrong answer. Yeah, there's no wrong answer today, okay? So what are some of the things that determine cardiac output? Yes, please. There's a gentleman trying to put up his hand, but he's afraid. So I'm going to, yes, tell me. Yes. Okay. And heart rate. Okay, systemic vascular resistance and heart rate. Thank you. We said there are no wrong answers. Okay, does someone have anything else they would like to say? Dr. Paluku, I choose you. Okay. Yes. And contractility. Okay. So, when we look at the cardiac output, as we've rightly said, we see all our answers were correct. It's determined by the heart rate, and it's also determined by the stroke volume, okay? So the heart rate is how fast the heart beats, right? And then the stroke volume is the amount of blood that the heart is able to eject with every beat, okay? So we're going to break those down now. Now, the heart rate, we've said it's how fast the heart beats. And the things that determine the heart rate are two. It's mainly innervation, and then we also have hormones. So for innervation, we know that the sympathetics will increase our heart rate, while the parasympathetics are going to decrease our heart rates, right? And then hormones, things like catecholamines and thyroid hormones, steroids are going to increase our heart rate, while other hormones like oxytocin, substance P, natriuretic peptides are going to drop our heart rates, which is why you see a lot of women as they advance during their time of pregnancy, the heart rates tend to drop, okay? So we come back to this. So we said that determinants, which are mainly the heart rate, which we've looked after, and then we also have stroke volume, okay? Now, when we're looking at stroke volume, we look at blood, the volume of the blood itself, okay? And then we also have vascular resistance. So now we are going to break that down. So Dr. Paluku said something interesting. He talked about preload, okay? Do we know what preload is? No wrong answer. I've looked at someone and they are looking down. There's no wrong answer. Yes, could someone tell me, what do you understand by a preload, if you've heard of the word preload? Yes? Mm-hmm. Okay. Okay, very good. So she said she thinks about the amount of blood present in the ventricles at the end of diastole. Do we agree? We agree, but there are no wrong answers, okay? So preload, these are just technical terms, but it's exactly what she said. So the tension developed by the stretch of the myocardial fibers, okay? And this is going to be influenced by the amount of volume that goes into these myocardial fibers, okay? So we all remember, I think, let me just, so when a muscle is contracting, okay, before it ejects, you remember that the sarcomeres or the muscle fibers are going to have to stretch themselves, right, to generate a force for that muscle to be able to contract, okay? So a preload is going to measure that amount of stretch, okay, that is in the myocardial fibers after blood comes back into the heart, either the right side of the heart or the left side of the heart. So which means that what determines that stretch is the amount of blood that comes back into that heart. Does that make sense? So if you have more blood coming in, it means the heart is going to stretch out more, okay? Right? And if you have less blood coming in, the fibers are not going to stretch as much. Does that make sense? Okay. So preload, so which means that if we have a higher venous return, we're going to have a higher preload. Okay? Easy, right? Yeah. So we are going to find a few laws as we go along. So there's Starling's law of the heart, okay, which states that the force of myocardial contraction is directly proportional to the end diastolic fiber length, which we've talked about, okay? So which means that if the heart is stretched more, it's going to have more force to squeeze. Does that make sense? Yes, okay? And so venous return will definitely contribute to the cardiac output, okay? Good. So what are some of the things that we think would determine preload from what we've understood so far? Yes? Tell us what you're whispering. Oh, no, don't look behind you. Preload. Preload, what we've talked about. Mm-hmm. Yes? Okay. Okay, very good. So we think that if the venous system dilates, we won't have as much blood going back to the heart, and that would reduce our preload. Makes sense, right? Okay. Anything else we think would influence our preload? Yes? Blood volume, very good. So you think if you have a higher blood volume, would you have a higher preload? Or is it a lower blood volume? A higher blood volume. Makes sense. Because more blood causes more stretch, which means our preload is higher. Okay? Anything else that we think? Yes, Dr. Paluku? Very good. How would the intrathoracic pressure affect? Very good. So when the intrathoracic pressure is high, then our venous return is going to reduce, and so our preload will be less. Any other pressure that would apart from the intrathoracic pressure? Yes? Okay, very good. What about the abdominal pressure? Would it also, the intra-abdominal pressure, would it affect preload? Yes, because it would reduce the amount of blood going in. Very good. So we've covered everything. So the circulating blood volume, which we talked about, and we explained that. Another thing is posture. We did not talk about posture, okay? We've heard about the passive leg raising test. When we position a patient that way, what happens to our preload? It increases because we recruit blood from the limbs and from the splanchnics, right? So posture also influences preload. Intracavitary pressures that we've looked at, which are intra-abdominal pressures, intrathoracic pressures, okay? And what about compliance of the ventricle? If you have a ventricle that's not very compliant, which means it doesn't stretch or it doesn't contract or dilate as it should, then it's going to limit the amount of blood that it's able to receive. Does that make sense? So when you have, say, a hypertrophied ventricle, the muscle is very thick. So even when it needs to relax, it tends not to relax as well. And so it can only receive a particular amount of volume. So in those patients, they will have issues with the preload, okay? The heart rate. Remember that when is the heart able to fill or to receive blood? Diastole. If the heart is beating too fast, it means that you reduce the diastolic time, right? So your preload is also going to to drop. Now, clinically, you're going to find some other terms that we're not going to dwell on so much, but they monitor preload usually by monitoring left ventricular end diastolic volume, left ventricular end diastolic pressures. That's for the left, and on the right it would be the others, the right ventricular end diastolic volume and right ventricular end diastolic pressure. Okay. Surrogates also include right atrial pressure, CVP. We shall not spend so much time on that. This graph just shows us that when you have a positive inotropic effect, then your cardiac output or your stroke volume is going to go high. And this is what we've talked about. And then the reverse is true when the graph shifts to the right. So we talked about, when we're talking about preload, it's important for us to talk about the passive leg raise, okay? Because it's something that we can use clinically to help us determine whether our patient would respond to volume in case they're in shock. Okay, so the first thing is you want to establish a baseline for your patient. So have them, position them at 45 degrees, okay, establish a baseline, get your baseline readings, right? Then next thing is you want to put the patient supine and then raise the limbs, okay? You raise the lower limbs, usually about 45 degrees, right? And then you don't want to stimulate the patient because you don't want confounders. We've already seen that if you stimulate and you wake someone up, you're probably going to trigger their sympathetics, release catecholamines, and what's going to happen to the heart rate? Go up. And that's going to confound or confuse your reading. So you want to keep your patient as calm as can be and just not do anything to agitate them. And then you raise the legs, right? And then we'll be able to reassess our cardiac output. If you have an echo, as Dr. Joan is going to talk to us about later, you can check if the feeling has improved. However, you can also look at your blood pressure readings. We expect that your systolic blood pressure will increase by between 8 and 12 for a positive response. Okay, this happens because when we position the patient that way, we're going to recruit blood from their lower limbs and from their splanchnic circulation and send this blood back to the heart, about 300 mils of blood. If the blood pressures go up, then we suspect, okay, this patient will benefit from volume, and then we can give volume. But as Dr. Cornelia said, not all patients in shock require fluids, okay? So this helps to guide us very easily clinically, okay? All right. Is it making sense? We are not sure. Okay. We're going to look at contractility next. So contractility, simply put again, contractility is the strength of ventricular contraction. That easy. Okay? Strength of ventricular contraction. So what are some of the things that would increase the strength of the ventricle contracting? Yes, Dr. Arthur? Okay, because we've talked about the stretch of the myocardial fibers. Yes. Okay, anything else? Are there some drugs that could increase? Yeah? Yes, please. Do you know some drugs that could increase the force with which the heart is contracting? It's okay to say no. You don't know, right? Okay. Does anyone know any drug that could increase? Yes, please. Okay, good. So there are certain inotropes that will act directly on the receptors around the heart to increase its force of contractility. So there are some drugs that can do that, okay? So other things that could increase include still the sympathetic nervous system, and a patient's metabolic state can also increase the force with which the heart contracts. If you have a hyperthermic patient, usually because the metabolic demands are higher, the heart has to beat stronger and a little faster, okay? And then the things that would reduce include hypoxia, hypercapnia, okay? Those things would depress the contractility of the heart. I had a patient this week who came out of theater, and for some reason his hemodynamics are great, and then in about 15 minutes they just drop. And we did the passive leg raising test, all of that, nothing, no response, and we're just scratching our head, what's going on, what's going on? We did an echo, the heart is squeezing well, but the pressures are down. You know, the maps just dropped to about 45. So we took off our gas, and the gas came back with a PO2 of 50. He was, at that point, I think we had put him on an FiO2 of 100, so the PO2 had dropped to 50, and his CO2 was 130. Okay? Yeah, so this is, a couple of things happened there, but it was because of his hypoxia and hypercapnia that his cardiac output dropped, or his blood pressure has dropped. Then the peripheral nervous system is also going to reduce the force of contractility. So it's very difficult to assess, or it's not possible to assess directly the force of contractility of the heart by measuring, how fast or how strongly the muscle fibers are contracting, right? But the surrogates that I use, the most accurate is echocardiography, and that is through ejection fraction, fractional area change. Some measurements can be done in the cath lab, but the most direct one is echocardiography. So, someone else was talking about afterload, okay? Now, afterload, simply put, is the ventricular wall tension that is required for the heart to eject a stroke volume, okay, during systole, okay? Are we together? Again, so it's the tension, a measurement of the tension that the ventricle requires to eject blood during systole, okay? Now, another law that, we'll just summarize this. But basically, Laplace said that when you have a sphere, okay, to measure the tension within that sphere is directly proportional to the radius and the pressure within that sphere. Too much science. What we are saying is the heart looks cylindrical, right? The afterload, we said, is that tension that it requires to squeeze, okay? Now, that tension is directly proportional to the diameter, the radius, okay, and the pressure that is generated, right? So if we have a fixed pressure, then it means that the radius, again, how much has come back in, or its ability to relax or contract, is going to either increase or decrease the afterload, okay? So it is very difficult to measure afterload directly, and so we use surrogates of measurement of afterload. We are going to see the surrogate very soon. But what are some of the things that we think would increase the tension of the heart to contract during systole? Yes? The young lady next to Paluku. I know Dr. Paluku very well, so now he's my reference point. Yes, please tell us. You're saying something. What are some of the things that you think? Okay, so the systemic vascular resistance. Okay, anything else that we're going to come to that? That's a very good answer. Anything else? What do we think would increase the demand of the heart to squeeze more as it's trying to eject blood? Yes? Please, a bit louder. Increased intrathoracic pressure, maybe not so much on the afterload side, like on the preload side. If the heart is squeezing against an obstruction, do we think it would increase its demand? It would, right? And some of the things that would have the heart squeezing against an obstruction, it could be a mechanical obstruction, like if we have a patient with aortic stenosis, the aortic valve is narrowed, right? Or if we have a membrane around there and the heart has to squeeze against that, okay? So we see that would increase the force that the heart has to contract against, okay? We also talked about the volume, the radius, right? If it feels more, the radius is more. That is for the left side. If you're looking at the right side, still you could have an anatomic obstruction. What anatomic obstruction could we have on the right side? Yes? This one, people are very, tell me. I'm just hearing S's. Yeah? Be bold, guys. Own it, own it. Yes? Okay, a pulmonary embolism. And very good. PS stenosis. Another stenosis? The valve itself, right? The pulmonary valve could also be stenosed. Okay. So, measuring afterload directly is not very easy, so we use surrogates, which is where she talked about comes in. The surrogates for afterload on the right side and the left side are pulmonary vascular resistance on the right side and then systemic vascular resistance on the left side. Okay? We are together. We've moved together up to this point, right? Right. Okay. So vascular resistance. Vascular resistance is the mechanical property of the vascular system opposing blood flow through it. Okay? The vascular system is obviously a tube or a pipe. Okay? And as blood flows through it, it will either oppose, there'll be a bit of opposition to that blood flow through it. Okay? It's just like when you're pouring water into, let's say, a bottle or a balloon. It will not take it indefinitely. You get to a point and you'll have to, something will have to give. So this happens in the vascular bed as well, in the vascular system. So there are two components. The resistance can be through flow. And for flow, this is mainly by friction determined by the viscosity of the blood, the resistance to the actual blood itself. Now, this is common in patients who have hyperviscosity syndromes. What conditions would give us that? Yes? Okay, someone just give me a hand. Because now it's getting hard to keep track of who's whispering. Yes, please. Very good. Patients who are polycythemic, okay? Yes? Do we agree on that? Yes. The blood is very thick, it's very viscous, it's hard for it to flow through the blood vessels, okay? Then the other component of that resistance to flow is a frequency-dependent or a reactive means, and this has to deal with the compliance of the blood vessels. Okay, if a vessel is not compliant, which means it has lost its ability to contract and relax as it should. If the compliance is not as good, then the resistance is going to be higher. Very good. And if the compliance is okay, then the resistance is going to be lower. Could you give me an example of a condition where compliance would be high? Don't worry, we are passing, right? Okay. Yes?
Yes. I'm looking at you. I like how he's kept his straight face. Yes, you. Anaphylaxis. We were asking for one where the compliance is not as good. Where the compliance? Yes. The blood vessels have thickened, right? Yeah. So there, the compliance is not as good. Okay. We talked about anaphylaxis. There you have, they've dilated, so your SVR is going to be low. Okay. Good. So the factors that affect vascular resistance on the pulmonary side and on the systemic side. So we've talked about vessel diameter. Vasodilatation is going to reduce the SVR. And then compliance with the systemic circulation. So in patients with atherosclerotic disease, they tend to have higher SVR. Then on the pulmonary side, still the vessel diameter will come into play there. Positive pressure ventilation is going to reduce compliance, and so you're going to have an increased pulmonary vascular resistance. When you have established PHT, usually there are microvascular changes that have happened, and so you find that compliance is not going to be as good, and figure it will be on the high side. We already discussed that viscosity and hematocrit. So while we are winding down, how does all this relate to blood pressure? When we're looking at blood pressure, we prefer to look at it in terms of mean arterial pressure, which is the organ diffusing pressure. Okay? And know that the mean arterial pressure is a product of the cardiac output and the systemic vascular resistance, because we are looking at systemic blood pressure, so we are on the systemic side. Okay? Yeah, so we can assume, because for a regular patient, they should not have issues with SVR. For a normal patient, so if SVR is constant, our cardiac output is very similar or directly related to our mean arterial pressure. Okay? So if you have a higher mean arterial pressure, you have a higher cardiac output. So we know this is just revision. Mean arterial pressure is a third systolic blood pressure 2/3 diastolic. At the end of the day, we see that diastolic blood pressure is going to determine mean arterial pressure a lot more than systolic blood pressure. So when you're looking at perfusion, it's very important to take note of your diastolic pressures as opposed to only your systolic pressures, and you need to take care of that. Okay? And we now understand what afterload means and how that affects our diastolic blood pressure. When we are to relate this to the cardiac output, we also need to know that there is no linear relationship between the mean arterial pressure and the cardiac output. Okay? As we've seen, the SPR is going to affect more than the cardiac output, which takes us back to some of the questions Dr. Kamal was asking us earlier. When you don't necessarily, you may have a patient with a normal blood pressure, but they're still insured. Okay? So these are some of the ways that we apply this. And increase in your blood pressure will not always mean that you're increasing your cardiac output. Okay? So I hope all the terms have made sense now. It's been a pleasure. Thank you. Thank you so much for having me. We're happy to take time to give us out, but